Hi, Elliot, and welcome back to another episode of the Irish Haematology Oncology Podcast. I'm your host, Eoin Tabb. I'm a pharmacist working in University Hospital Waterford. And we're going to take it back up fairly quickly from last week, and we're going to talk about those other ancillary medications that are the bits and bobs of chemo treatments that I've compiled together in this dual episode list. I've definitely forgotten about a couple of things, but you might add in a comments or show notes or whatever, some of the ones that I might have forgotten about. So we're going to pick up today with cisplatin hydration, and we'll move on from there. So let's start with the basics. Hydration. We all know how important it is to stay hydrated, especially when we're exercising or spending time in the heat. But did you know that hydration is equally crucial for patients undergoing chemotherapy? You see, many chemotherapy drugs can be quite harsh on the kidneys. If we don't ensure our patients are adequately hydrated, these drugs can cause dehydration and even kidney damage. It's a bit like running a marathon without drinking enough water. Your body simply can't function properly. So cisplatin is a cornerstone chemotherapy drug in the treatment of various cancers. It's particularly notorious for its potential to cause kidney damage, a condition which is known as nephrotoxicity. This is due to the drug's accumulation in the kidneys, leading to direct renal cell injury, inflammation, vasoconstriction, and ultimately cell death in the kidneys. The risk of this damage increases with higher doses of cisplatin. Previous exposure to the drug, concurrent use of other nephrotoxic medications, and pre-existing conditions like hypertension and kidney dysfunction. So to mitigate this risk, hydration protocols are a fundamental aspect of cisplatin administration. The goal is to maintain an adequate fluid volume in the body, which helps to dilute the drug in the bloodstream and promote its excretion through the kidneys. Think of it like flushing a toxin out of a system with a steady stream of water. The more water flowing, the quicker and more effectively the toxin is removed. So, hydration protocols for cisplatin typically involve three distinct phases: pre-hydration, sometimes current hydration, and post-hydration. So depending on your own local protocol or national protocol, these might differ. So let me just go through what each of them could be. Pre-hydration. This phase involves administering a large volume of fluids, usually isotonic saline or 0.9% sodium chloride, before the cisplatin infusion. This helps to prime the kidneys, increasing urine flow and preparing them for the influx of the drug. The amount of pre-hydration fluid can vary, while typically around a litre, given over 1 to 2 hours. Now we'll move on to concurrent hydration. So during the cisplatin infusion, we continue to hydrate the patient with additional fluids, usually another 1,000 ml or litre of saline. This helps to dilute the cisplatin further and maintain a steady flow of urine, facilitating the drug's excretion and minimizing its contact time with the kidneys. That 1,000 ml of saline I'm talking about there, though, that's oftentimes what the cisplatin is diluted in. So the cisplatin infusion itself acts as a concurrent hydration. It hydrates the patient during the cisplatin infusion. And now we'll go on to post-hydration. So after the fusion is complete, we continue hydrating the patient for several hours, typically with another 1,000 ml of saline. This final phase ensures that any remaining cisplatin is flushed out of the system, further reducing the risk of kidney damage. The most common fluid used for hydration is normal saline, as it's isotonic and doesn't cause any fluid shifts in the body. However, we also might add in electrolyte solutions, which contain additional minerals like potassium and magnesium. These minerals can be depleted by cisplatin, so replenishing them helps to prevent electrolyte imbalances and potentially reduce the risk of kidney damage. We look at the potassium levels and magnesium levels. If they're at a hyperkalemic level or a hypermagnesiemic level, we won't add in these electrolytes. But if they're in the normal range, we tend to add them in because we know that they will go into a hypo level if they're being depleted by the cisplatin. While hydration is crucial, it's not a one-size-fits-all approach. The specific hydration protocol can vary depending on several factors, including the cisplatin dose, the patient's kidney function, and any other concurrent medications that they're taking. So take, for example, if a patient is getting etoposide in 1,000 mils of saline, this may act as a pre or post hydration part of the protocol, negating the need for additional hydration. I hope that makes sense. Also, in patients with pre-existing kidney dysfunction, they might require a modified hydration regimen or a lower dose of cisplatin. In addition to hydration, other strategies can be employed to minimize the risk of cisplatin-induced nephrotoxicity. These include using less nephrotoxic chemotherapy drugs when possible, monitoring for kidney function closely throughout the treatment, and adjusting the cisplatin dose based on the patient's kidney function. By understanding the importance of hydration and implementing appropriate protocols, we can significantly reduce the risk of cisplatin-induced nephrotoxicity and ensure that our patients receive the full benefits of this powerful chemotherapy drug. Now let's shift our gaze to methotrexate. Similar to cisplatin, methotrexate, a chemotherapy drug used to treat various cancers like lymphomas and leukemias, can also require careful attention to hydration. However, the rationale behind hydration in methotrexate regimens is twofold: preventing kidney damage and minimizing the risk of methotrexate-induced nephrotoxicity. Methotrexate is primarily excreted through the kidneys. High doses of methotrexate can overwhelm the kidney's ability to eliminate the drug, leading to its accumulation and potential damage to the renal tubules. This can manifest as acute kidney injury, which is a serious condition that can disrupt kidney dysfunction and lead to complications. Additionally, methotrexate can precipitate in the renal tubules, forming crystals that can obstruct urine flow and further exacerbate kidney damage. This is particularly a concern in acidic urine, as methotrexate is less soluble in acidic environments. To mitigate these risks, we employ a two-pronged approach: hydration and alkalinization. I always find that word difficult to say. Hydration, as we've discussed, involves administering intravenous fluids to dilute the methotrexate and promote its excretion. This helps to prevent the drug from reaching toxic levels in the kidney and reduces the risk of crystal formation. Alkalinization involves making the urine less acidic, typically by administering sodium bicarbonate. This increases the solubility of methotrexate, making it less likely to form crystals in renal tubules. Think of it like adding baking soda to vinegar. It neutralizes the acid and prevents a reaction. In addition to hydration and alkalinization, we often use folinic acid, also known as leucovorin, in methotrexate regimens. Similar to what we were speaking in the previous episode, that's used in combination with 5-FU. Folinic acid is a form of folic acid, a vitamin that's essential for cell growth and division. Methotrexate works by inhibiting an enzyme that converts folic acid into its active form, thereby disrupting DNA synthesis and cell division in rapidly dividing cancer cells. However, this mechanism can also affect healthy cells, particularly those in the bone marrow and gastrointestinal tract, leading to side effects like low blood cell counts and mucositis. Folinic acid acts as a rescue agent by bypassing the enzyme inhibited by methotrexate, providing the cells with the active form of folic acid they need to survive and function. The specific dosage and schedule of hydration, alkalinization, and folinic acid rescue can vary depending on the methotrexate regimen being used. However, the general principle is to start hydration and alkalinization before the methotrexate infusion, continue them during the infusion, and maintain them for a period after the infusion is complete. Folinic acid rescue is typically started 24 hours after the methotrexate infusion and continued until the methotrexate level in the blood falls below a certain threshold, normally 0.1 or 0.05 micromoles per litre. It's crucial to monitor patients closely during and after methotrexate treatment, paying particular attention to their kidney function, electrolyte levels, and urine pH. This allows us to adjust the hydration and alkalization regimen as needed and ensure that the folinic acid rescue is effective. By understanding the rationale behind these supportive measures and implementing them meticulously, we can minimize the risk of methotrexate-induced nephrotoxicity and other side effects, ensuring that our patients receive the full benefits of this valuable chemotherapy drug. Finally, let's talk about the role of Mesna in cyclophosphamide and ifosfamide regimens. These are powerful chemotherapy drugs used in the treatment of various cancers, but they can also cause a serious side effect called hemorrhagic cystitis. This condition is characterized by inflammation and damage to the bladder lining, which can lead to bleeding, pain, and an increased risk of infection. The culprit behind hemorrhagic cystitis in these regimens is a toxic metabolite known as acrolein. Both cyclophosphamide and ifosfamide are metabolized in the liver to produce acrolein, which is then excreted by the kidneys into the urine. When acrolein comes into contact with the bladder lining, it can cause significant damage, leading to the symptom of hemorrhagic cystitis. Mesna acts as a protective agent by binding to acrolein in the urine, neutralizing it before it can cause damage to the bladder lining. Think of it like a shield, deflecting the harmful acrolein away from the delicate bladder tissue. The dosage of Mesna is typically based on the dose of chemotherapy drug being administered. For ifosfamide, the recommended dose of Mesna is usually equal to the dose of ifosfamide given in divided doses before, during, and after the ifosfamide infusion. It can range from, as I said there, 100%, sometimes up to 140, 160% of that ifosfamide dose. For cyclophosphamide, Mesna may be used in high-dose regimens, so dosages of 50 mg per kg or 2 grams per meter squared or greater, and the daily dose is typically 1 to 1.5 times the daily dose of cyclophosphamide. Mesna can be administered intravenously or orally. The intravenous route is often preferred for its faster onset of action and more reliable absorption, especially in patients who may have difficulty absorbing oral medications due to nausea or vomiting. The handy thing about the oral Mesna is it can be given as a discharge prescription, negating the need for the patient to have to wait in the oncology or hematology day ward until it has been administered. While Mesna is generally safe and well tolerated, it's important to note that it doesn't completely eliminate the risk of hemorrhagic cystitis. Some patients may still experience mild symptoms despite Mesna prophylaxis. Therefore, it's crucial to monitor patients closely for any signs of bladder irritation or bleeding and to provide additional supportive care as needed. In addition to Mesna, other strategies can be employed to reduce the risk of hemorrhagic cystitis, such as ensuring adequate hydration, encouraging frequent urination, and avoiding bladder irritants like caffeine and alcohol. By understanding the role of Mesna and implementing appropriate preventive measures, we can significantly reduce the risk of hemorrhagic cystitis and improve the overall experience for patients undergoing treatment with cyclophosphamide or ifosfamide. So there you have it. A comprehensive look at some key ancillary medications that we use in chemotherapy regimens. We've covered everything here from vitamins and steroids to hydration protocols and bladder protectants. Remember, these medications aren't the star of the show, but they're the indispensable supporting actors. They're ensuring the safety and efficacy of our chemotherapy regimens. It's important for us to understand these medications, their interactions with specific chemo drugs, and how to adjust them for individual patients. We can minimize side effects, enhance treatment efficacy, and ultimately improve the lives and that cancer journey for our patients. I encourage you to share your thoughts and feedback on this episode by filling out our feedback form. Your input is invaluable in helping me improve this show and tailor future topics to your interests and things that I might have missed out on. Thanks a million, guys, for this reaching the end of this 2-part series. And again, I do encourage you to use the CPD form if you're a pharmacist, and if you're a nurse or physician listening to the show, please contact me and let me know if there's any needs that I can help out with your CPD recording. As always, I'll end the podcast on this important disclaimer. This podcast is for educational purposes only. Remember, the field of cancer care is always advancing, and new research may lead to changes in treatment approaches or protocols. Always consult with your own team for personalized guidance and discuss any information from this podcast with them. Seek information from trusted local and national resources for the most up-to-date recommendations. Thanks again, guys, for joining me this week, and until next week, talk to you.